Upon completion of this course, the participant will be able to identify specific sinus rhythms and describe specific characteristics, causes, and treatment for each, identify specific junctional rhythms and describe specific characteristics, causes, and treatment for each, identify specific ventricular rhythms and describe specific characteristics, causes, and treatment for each, and identify specific heart block rhythms and describe specific characteristics, causes, and treatment for each. Mr. Smith has a sinus tachycardia of 110, and the last time he checked, everything seemed fine. Then suddenly, the alarm goes off and the monitors indicate he is in atrial fibrillation with a ventricular rate of 130 to 140. You take a breath, assess the patient, and discover that he can't breathe. His chest hurts and his blood pressure is dangerously low. You recognize that he is unstable and uncontrolled in his ventricular response, and you act accordingly. You get the code card and begin setting up for cardioversion. While this is certainly a scary scenario for the patient, it does not have to be for you. Being confident in your knowledge of how heart rhythms work, how to accurately read an ECG, how to differentiate between the many different rhythm abnormalities you may encounter, and finally, how to respond appropriately with the proper diagnosis and treatment will keep you focused and on task during even the most stressful situation. While the differences in heart rhythms may seem subtle, the differences in how to treat them can be significant. This course will methodically walk you through each rhythm and equip you with the information you need to properly assess and treat your patients with abnormal rhythms. First, let's take the individual parts of the ECG, the atrial and ventricular rhythm and rate, the PR interval, and the QRS, and let's put them together so we can begin naming the different rhythms in a systematic way. We'll begin with rhythms that originate in the SA node, which serves as the heart's normal pacemaker. Of course, pacemaker cells in other areas of the heart can also depolarize, but it is the SA node cells that usually dominate the heart's electrical activity. Sinus rhythms originate with the SA node and follow the normal path of conduction to the ventricles from the sinus node to the atria and AV node, through the bundle of His, along the bundle branches, and finally through the Purkinje fibers, where depolarization takes place. Let's examine the ECG characteristics for normal sinus rhythms. Rate. The normal sinus rhythm has an intrinsic rate of between 60 and 100 beats per minute. Rhythm. Both the atrial and ventricular rhythms are regular. P waves. Uniform in appearance and followed by a QRS, they usually appear with a positive deflection, depending on the lead used. PR interval. 0.12 to 0.20 seconds and constant from complex to complex. QRS. 0.04 to 0.10 seconds and constant from complex to complex.
A dysrhythmia is an abnormal rhythm, which by definition is any rhythm that doesn't follow the normal pathway of conduction, starting from the SA node working its way down. A dysrhythmia can have many causes, including the use of drugs, both prescribed and illicit, electrolyte disturbances, myocardial infarction, and certain medical procedures. A dysrhythmia is a heartbeat that is either too rapid, greater than 100 beats per minute, which is called tachycardia, or too slow, less than 60 beats per minute, known as bradycardia. Remember, however, not to get caught up in the numbers game. You are there to treat the patient, not the monitor. Always be alert for changes in patient condition and respond accordingly.
Let's look at dysrhythmias in more detail. First, there is sinus bradycardia, the term used to describe a sinus rhythm with a rate fewer than 60 beats per minute. If the patient's SA node fires electrical impulses at that slow rate, but the impulses continue through the normal conduction pathway in the atria, AV junction, bundle branches, and Purkinje fibers, the patient has sinus bradycardia. In other words, the sinus node is functioning properly, but it is firing at a rate that is too slow. The explanation for the condition is that the parasympathetic nervous system, innervated by the vagus nerve, has simply slowed things down.
Let's examine the ECG characteristics for a sinus bradycardia. As you will see, it follows all the criteria for normal sinus rhythm except for the rate. Rate. Atrial and ventricular rates are less than 60 beats per minute. Rhythm. Atrial and ventricular rhythms are regular. P waves. Uniform in appearance and followed by a QRS. PRI, 0.12 to 0.20 seconds. QRS, 0.04 to 0.10 seconds. As with many heart irregularities, the cause of sinus bradycardia, or SB, is not always problematic. In fact, the slower rate may actually be in the normal range for some patients, especially athletes. It may also be present in healthy patients during sleep or deep relaxation. Sinus bradycardia can be caused by changes in the body including hypothermia, hypothyroidism, cardiomyopathy, MI, and heart block. In addition, certain drugs such as digoxin, beta blockers, calcium channel blockers, and interestingly enough, even some antiarrhythmic medications can induce a slower heart rate. When deciding if or how to intervene when a patient is experiencing sinus bradycardia, it is critical to follow a specific process. First, as always, remember to focus on the needs of the patient, not the readings from the monitor. Be sure to thoroughly assess the patient following the CABs of assessment, which, as you know, are circulation, airway, and breathing. And don't forget to check the blood pressure. The outcome of your assessment will always guide your treatment choice as you work to determine and fix the underlying cause of the problem. If the SB patient is asymptomatic, no immediate treatment may be required. However, you should continue to monitor and assess the patient to make sure no symptoms develop. If the patient is sleeping, very relaxed, or this is a normal rate for them, you do not need to intervene. However, if the patient does have symptoms that cause you concern, such as cold or clammy skin, hypotension, shortness of breath, dizziness, chest pain, blurred vision, or syncope, they need to be addressed right away. The proper treatment for sinus bradycardia includes the use of oxygen, an IV line, atropine, transcutaneous pacer, dopamine, or epinephrine. Now, let's take a closer look at a couple of the drugs used to treat sinus bradycardia. The first is atropine, a cholinergic blocking agent that increases the firing power of the SA node and improves conduction through the AV node. With SB, we must be concerned with the operation of the ventricles. By increasing conduction through the AV node, we will get more impulses down to the ventricles, which will in turn increase the heart rate. So, simply put, atropine will increase AV nodal conduction to get more impulses through the ventricles, bringing the heart rate into normal range. Atropine may be given in a dose of 0.5 milligrams as a quick IV push. If given too slowly, atropine can actually have the opposite of the desired effect. It can send the patient into a more severe bradycardia called paradoxical bradycardia, which will slow the heart rate down even more. Dopamine or epinephrine, which have similar results, may also be given in a continuous IV infusion. The treatment of sinus bradycardia with atropine or one of the other drugs is certainly not a situation that you can administer the prescribed dose and then move on to other tasks right away. You need to closely monitor the patient's responses and continuously check for symptoms, including causing the heart to beat too fast. The patient can respond poorly to the treatment and put you in a position to deal with brand new challenges. One last caution on the use of atropine. Be cautious when using it in the presence of acute myocardial ischemia, because it may worsen the condition.
Now that we have looked at a slow sinus rhythm, let's explore our options in dealing with sinus tachycardia, or faster than normal rhythm measuring between 100 and 150 beats per minute. As with sinus bradycardia, the patient's SA node fires electrical impulses that pass through the normal conduction pathway in the atria, AV junction, bundle branches, and ventricles, but in the case of sinus tachycardia, those impulses are firing too fast. Again, the sinus node is functioning properly, but it is not firing at the correct speed. Be aware that if the rate is greater than 150, it is probably not sinus tachycardia, so quickly and carefully evaluate the situation and respond accordingly. Let's examine the ECG characteristics for sinus tachycardia. It follows all of the criteria for normal sinus rhythm except for the rate. Rate: atrial and ventricular rates are between 100 and 150 beats per minute. Rhythm: atrial and ventricular rhythms are regular. P waves: uniform in appearance and followed by a QRS. PR interval: 0.12 to 0.20 seconds. QRS: 0.04 to 0.10 seconds. With the increased rate and rapid depolarization, you might lose a T wave, in which case you would have a P, then a QRS, then another P wave. You must identify the P waves and march them out. Just as the slowing of the heart rate is not necessarily a cause for alarm, the speeding up of the sinus rhythm, even to the point of being sinus tachycardia, may be just a normal response to a variety of factors including exercise, pain, stress, anxiety, fear, or other strong emotions. Sinus tachycardia can also occur when the body's demand for oxygen increases because of infections, fever, hypoxia, shock, dehydration, congestive heart failure, or MI. There are many prescribed drugs, including atropine, dopamine, dobutamine, and epinephrine, that can cause sinus tachycardia, and there are even more chemicals taken unwisely or illegally that can cause real problems for a patient's sinus rhythm. These include alcohol, caffeine, and a whole variety of illicit drugs. While their effects will eventually wear off, the impact on the heart can be dangerous or even fatal. In determining if or how to treat a patient with sinus tachycardia, be sure to first carefully assess the condition of the patient and then make a plan to treat the underlying cause of the symptoms they are exhibiting. For example, if the patient is in pain, relieve the pain. If they are dehydrated, immediately replace fluids, and so on. After those symptoms are taken care of, you can concentrate on the source of the problem. So far, we have been looking at dysrhythmias characterized by impulses that are either too fast or too slow. Now we shift to sinus arrhythmias in which the SA node actually fires impulses irregularly. Sometimes this condition is related to respiratory cycles and interthoracic pressure changes. Sinus arrhythmias follow all the criteria for normal sinus rhythms, except that the P waves and the QRSs do not march out. The distance between the P to P and the R to R is irregular, and the rate increases with inspiration, which means the R to R intervals shorten, and then decreases with expiration when the R to R intervals lengthen. With sinus arrhythmias, the atrial and ventricular rate is the same because the sinus node is still firing, and the PR intervals are regular, but the atrial and ventricular rhythms will be irregular. That is the key point to remember. With sinus arrhythmias, atrial and ventricular rhythms will be irregular, while everything else will be normal. Let's examine the ECG characteristics for sinus arrhythmias. Rate. Atrial and ventricular rates are usually normal in the 60 to 100 beats per minute range. Rhythm. Atrial and ventricular are irregular. P waves. P to P and R to R intervals are irregular. PR interval, 0.12 to 0.20 seconds. QRS, 0.04 to 0.10 seconds. Sinus arrhythmias can have many causes and come from a variety of sources. They are common for patients on ventilators because of the expected change in the intrathoracic pressure, which can sometimes affect the sinus rhythm. You may also see sinus arrhythmias with an MI, with infants and children, and with the elderly, because of conditions associated with aging such as heart disease, post-MI, or an increase in intracranial pressure. There are also some medications that may cause arrhythmias, including digitalis and morphine. Sinus arrhythmias are generally benign and usually require no intervention. But as with all heart irregularities, you must be alert for problem signs and symptoms that may be present. This sinus arrhythmia provides a cause for pause, literally. A sinus arrest, sometimes called a sinus pause, occurs when the SA node fails to discharge an impulse, creating a pause in the rhythm before it randomly resumes. During a sinus arrest, there is no electrical activity at all, no P, no QRS, not even a T. The SA node fails to initiate an impulse, and unfortunately there is no backup plan. When a patient is experiencing these pauses, the underlying rhythm is still a sinus rhythm, so you look for missed beats and anything that is abnormal. If it is indeed sinus arrest, you will see a normal sinus rhythm with a pause. Pay special attention to the frequency and duration of the pauses, as prolonged pauses can cause serious problems and would require intervention. Let's look at the ECG characteristics for a sinus pause. Rate. It is usually normal, but may vary immediately before and after the pause. Rhythm. The basic or underlying rhythm is regular except for the missed beat or pause. P waves. They are absent for the missed beat, but are regular for each of the other impulses. PR interval, 0.12 to 0.20 seconds. They are absent for missed beats and are regular for other impulses. QRS, 0.04 to 0.10 seconds. It follows all P waves except when the beat is missed, then the QRS will be absent. There are several causes for sinus arrests, including hypoxia, myocardial infarction, and myocardial ischemia. It can also be caused by reactions to certain medications. When dealing with a patient suffering from sinus arrest, you want to carefully measure the length of the pause, counting the number of boxes between the P waves and then multiplying that number by 0.04. The treatment for sinus arrest begins with assessing the patient. If they are asymptomatic, it is probably an isolated event and is not a problem. But because it may be problematic if the pauses recur, be sure to record the event on the patient's chart to inform the doctor of the event. If the patient is symptomatic, intervention is required. Symptoms include episodes that are frequent and/or prolonged, which is defined by lasting more than 3 seconds, or if the patient is showing signs of dizziness, weakness, syncope, or lightheadedness. In any of these cases, be sure to notify the physician immediately, as a pacemaker may be required.